Well, hello everyone, and thank you for attending our COVID-19 webinar follow-up series. My name is Holly Foxworth. I'm a registered nurse with Axiom Medical, and I'm also joined by President and CEO Mark Robinson. Welcome to the live stream, Mark. I appreciate you joining.
Thank you, Holly. It's a pleasure to be here.
Great. Well, Mark, I know that we all really enjoyed the webinar last week that you had with Dr. Rick Fernandez, who was the Assistant Superintendent of Tomball ISD, and you guys had discussed some of the variables that school districts would need to consider for successful reentry to education. But for those that may have been unable to join, you guys spoke about a new Axiom partnership. Is that correct?
Yes, we did. We through another partner, a mutual partner, we're introduced to one another because we have a set of products that help people in the private sector return to work safely and stay safe at work in this COVID era. And we worked with Tomball ISD to adapt our product set to their specific needs for staff and faculty. And we were able to put together a really great public-private partnership that helps keep our teachers and the other people working in our schools safe.
Wow. And so yes, absolutely. And so are they going to be actually using the Check-in to Work app then?
Yes, that's exactly right. They're going to be using the Check-in to Work app, which is a simple app that pre-screens individuals before they set off for the workplace for specific risks, either symptoms or exposures. If they are considered to be at risk, they're asked to call our call center before heading into work, and our screeners will take them through a much more detailed screen and determine if they can safely enter the workplace or not, and in this case, safely enter the school or not. If they're cleared on the initial screen, they get a green flag and they can go right to school. And of course, we notify the school that either they've been cleared or they've been flagged, and subsequently what happens.
Wow, that's great. Well, Mark, I know that I and all of the team at Axiom are really excited about that relationship. This is an excellent opportunity, and we definitely consider it an honor to be able to kind of provide them with some enhanced healthcare services for their district. But moving forward, as you and I'm sure everyone else in America has noticed this week, the subject of how students and teachers and staff are going to be able to resume education has really been a hot topic. Families and policymakers have had to consider really the full spectrum of benefits and risks for both that in-person learning experience and a virtual learning options. So we know, aside from the child's home, that there's not really another setting that has an influence on the child's health and well-being like what their school is. But understandably, there's a lot of concerns. People have a lot of concerns about safety. So there's a lot of moving parts here. So many considerations have been made in determining what decisions are most appropriate for each district. But we did have several questions that we were hoping that you'd be able to give us some insight on. Amy was the first one and had asked how COVID-19 really differs between children and adults.
Yeah, so for very young children, it's somewhat different in terms of the symptoms that they are at risk of. And also, children under 5 seem to, from latest research, seem to potentially be super spreaders of the disease, as in they carry a much higher viral load than older children or adults do, and therefore are more likely to be able to share that the virus with others. But when we get into what I'll say post-kindergarten students, children, they are not materially different in their risk of the disease or the worst case consequences. Fortunately, children have much more robust immune systems than many adults do. They're generally in better health, and generally they're able to shake COVID off with a relatively mild set of symptoms or no symptoms at all. Although there can be hidden consequences that emerge down the line from the time they're infected. Organ issues and various other issues. Whereas adults, and another factor is that children are way less likely to have comorbidities, that is, other diseases at the same time as COVID, for example, hypertension, cardiovascular disease, autoimmune diseases, etc. All of these make the prognosis from catching COVID worse and are more prevalent in older adults. And in fact, the older the adult, the higher the concentration of additional diseases that make them more vulnerable.
Okay, and it looked like that in terms of some of the CDC numbers and things like that they were reporting on, less than 10% of the cases that were reported under the age of 18. Is that correct?
Yeah, and I think to some extent that's not because there are necessarily fewer children who are getting COVID. It's that most of them, or a larger percentage of them, are asymptomatic.
Sure.
Because their innate immune system is able to tackle the disease from the get-go. They never get into the position where their body's generating antibodies and their inflammatory systems are involved, and so basically they recover quickly without apparent symptoms, and therefore don't get tested and don't seek medical treatment. So it's likely that the frequency of COVID is more or less identical in the population of children as it is in the population of adults.
Okay. Well, the next question that we had came from Charles, and he was asking about active surveillance. He was asking what type of active surveillance that districts should be utilizing for their students, teachers, and staff.
Okay, so I'm not willing to be prescriptive about this.
Okay.
But basically, syndromic surveillance, which is where you're looking for symptoms or specific risk factors that make you potentially vulnerable to or actually have COVID. Syndromic surveillance is the most effective way to prevent infection between individuals. Syndromic surveillance followed by isolation of those who have primary exposures or who are symptomatic. In the case of a school, and students, teachers, and staff, our number one objective is to keep people who are symptomatic out of the school. Mm-hmm. This includes keeping people who have a primary exposure. That means they've been exposed directly to somebody who is currently symptomatic or who became symptomatic shortly after that exposure. So what we want to do is ask a set of questions every single day that identify whether an individual who's seeking to access the school, be it teacher, non-teaching staff, or student, or parent coming in for a teacher conference or whatever, we want to make sure that those individuals aren't bringing COVID into the school. So questions, best way, and then making sure that they don't get entry if their question set is indicative that they have an issue. Just a couple more quick things on that, though. People forget that there's the risk to the individual in the workplace, in the school, where they get the disease or transmit the disease. But people tend to forget that there's an equal and probably even greater risk that somebody gets infected, let's say in school, and they go home, and it's a child, let's say, but they have parents and potentially grandparents in the home with them. There may be people who are immunocompromised, people who have hypertension, other comorbidities, or the teacher may well be going home to an environment where they have a life partner, a spouse, or a live-in parent, who are all more vulnerable to the disease than the individuals who got it in the first place. And that, as well as the risk of what happens in the school and to the people who go to the school, we need to be responsibly concerned over what happens outside the school to the immediate contacts of those people who become infected.
All great points. You know, the other question that comes along with that, I think that the biggest question that every district faces is how is it that you can manage that on a large scale, considering that most don't have the additional personnel and resources to assume some of these new responsibilities?
Yeah, well, technology and third-party support is really the only way to do it. if you're in a school district that has, let's say it's somewhere like Tomball, and you have plus or minus 20,000 students and 3,000 staff, plus or minus. How are you going to staff to verbally ask those questions every day of every person? So you have to have technology. And then even if you have technology, how are you going to do the secondary screening that lets you determine if they trip a trigger in those first 5 or 6 questions? How do you go deeper? How do you keep current with the right questions to be asking? Because CDC, World Health Organization, Johns Hopkins guidance is constantly evolving in this regard. What are symptoms? What do they look like? How long is an exposure a risk? How long prior to symptoms were you infectious, and therefore how likely is it that you transmitted? So very hard for a school district or any institution that isn't in this field to do an effective job of this on their own, unless they're enormous and they can throw very large amounts of resource at it.
So could technically then, so some of the apps that Axiom offers, not that we're just self-promoting, but I mean, some of the apps that we offer for both check into school and check into work could really help in terms of resources in some of these areas.
Yeah, they absolutely could. And just to be clear, there are other service providers who have app-based solutions that can be helpful as well. And I'm not trying to throw Axiom out there as the only solution. I obviously have pride of ownership and think it's the best, but any school district seeking a partner to help with this should do their due diligence. They should research the market, and they should have exploratory conversations with multiple providers if they can find them. We didn't get into the school sector specifically to make money. We're a for-profit organization, but we got into this as a public-private partnership to do a social good. I think it's critical that our teachers and our students are well cared for and kept as safe as possible. It's not I'm not in any way interested in the politics of whether schools reopen or schools don't reopen. That is an area where I'm not expressing any opinion at all. All I'm interested in is for those schools that do reopen, how can we or others help them be as safe as possible and do it as economically as feasible?
You bet. You bet. Well, Joel had asked, and I know that we've answered this question so many times before, working closely with employers, but for school districts, this is kind of a new concept to them. It's not as familiar. But what are some of the strategies that schools can use to help reduce the spread of COVID-19?
Yeah. Basically, we've already talked about one, which is controlling access. And I think that is singly the most critical thing that can be done. Secondly, we've got occupancy. How do you manage occupancy? You can't cram a classroom with 50 kids and expect that they're going to be able to maintain a safe distance from one another, even wearing masks. Right. So what you need to do is figure out the maximum occupancy that you can have in any room or place within the school, and take into account the need to wear masks, the need to keep that minimum 6 feet distance apart. Think about planning for fewer people in each room, and the second thing that you can do is activity. So what activities are these students and teachers participating in? Singing, shouting, loud speaking, all of which create aerosolized plume of virus particles from somebody who's infected, are highly discouraged. Don't have choir practice. Don't do a pep rally. Don't basically do anything that causes an excess of excitement in a closed environment. Second, so that's activity. Then motion. Okay, so you have to think about how people will move around the building, how often they move, from where to where. How do you stage that movement so that corridors and hallways are not over-occupied so that the press of people up against each other increases the risk of infection? How do you route people around the schools so that, to the greatest extent possible, they're moving in the same direction rather than moving against each other? So stagger the timing, manage things so that actually maybe students stay in one room for most of the curriculum and teachers move. Or, it gets complex because there are electives amongst older kids as well, and that people aren't necessarily in the same groups all the time. But this is a challenge I know that our friends at Tomball ISD have looked at really closely and done a lot of work to figure out how they can manage movement. And the final thing is hygiene. It touched on it in occupancy. Masks do make a difference. I know there's some, again, political controversy about that, but anything that reduces the distance that a plume of infected, aerosolized virus particles can travel from your mouth or your nose, anything that reduces that distance reduces the probability that you can infect somebody else. And masks of every kind have varying levels of effect, from low to high, in reducing that distance that you're basically spraying out virus. If both of you are masked who are within 6 feet of each other, it's less likely even still that you'll inhale the virus plume. And keep this in mind. Severe cases often occur because somebody inhaled a heck of a lot of it, right? Sure. The viral load, the initial viral load, how many viral particles that you bring into your body on that exposure, that is a big determinant of how quickly and how severely you will become ill. A very light viral load, that increases the probability that your innate immune system can deal with the infection before it becomes involved, before it becomes a complex infection, has secondary symptoms, and makes you very ill. So, and hygiene obviously includes sanitation, so hand washing regularly, hand sanitizers inside or outside the door to classrooms, and generally surfaces that are touched frequently, hard surfaces touched frequently by a lot of people, should be cleaned with an appropriate cleaner. And there are many lists of these cleaners that are now available from CDC, for example, that will sterilize that surface.
Great points.
That's all I can give.
And those are excellent. Yes, and I think that you hit on every single one of them. Lisa had asked about complacency, and I know that you've addressed this whenever we've talked about it with employers before. But how do you feel like complacency is going to factor into the equation here for not just the initial reentry, but being able to continue that face-to-face education?
I think that perhaps less now than maybe 6 or 8 weeks ago. After what was called the first wave of COVID, when states began to relax their constraints and people began to re-engage in behaviors that had been unavailable to them for a while, going to gatherings, eating out, bars, restaurants, pubs, all that kind of stuff, or just gathering together for family reunions or going to church, or any of those things that put lots of people in close proximity for an extended period of time. Then we saw this what I think is not correctly called a second wave. I think this virus is more like actually a brush fire, right? It's just going to keep on burning through the population, and there's no evidence that it's coming and going in waves. The waves are an artifact of the rate at which people get infected, which is directly linked to the behavior of the people. So over the last 6 weeks or so, we've seen a massive uptick in case rates in most of the US. States that had not been adversely affected in the first place, rural states, heartland states. My own spiritual home in Montana began to see a very high instance of infection. The second time round, it has not been characterized, at least to this point, with the same death rate that the first wave, quotes, was characterized by. And that's for a bunch of reasons. A lot of people were in nursing homes and died from and they were elderly, they had comorbidities, and they were in relatively close proximity, and we didn't know much about the disease at the time. So nursing home deaths contributed hugely to the total death rate in the first wave. But the thing we should focus on is not how many people die, although that is tragic and it is deeply sad for society and for the individuals. What we should be focused on is how many people get severely ill enough to need hospitalization, and therefore swamp our resources, our ICUs, our critical care beds, our critical care professionals, right? How many people get seriously ill? Because of many of those people actually will never be the same again. Many of those people suffer from organ damage that is permanent or at least sustained in the long term. Many of them will take a long time to recover to normal function, even if they do recover to normal function. It's not unusual for people who've been severely ill with COVID, and we're now 5 or 6 months into this in the US. It's not unusual to see people who are still recovering who got the disease in March. So that's the thing we have to be cognizant of. It's the use of resource and the consequence of severe infections. So I think this has become more and more understood. I think a larger swathe of the population actually understand that wearing a mask, choosing to wear a mask in public, choosing not to gather together in large crowds, choosing to manage your life in a way to reduce your risk, but also reduce everybody else's risk. That's a caring and compassionate choice to make. I'm not, again, going to get into whether government should or shouldn't mandate such things. But as individual humans, we should all be capable of looking at how we behave and being responsible and accountable for it. And if we're deliberately choosing to behave in ways that expose other people to risk, we should ask ourselves why we're doing that. Personal opinion, of course. So I think complacency will play less of a role, particularly in schools, than I would have thought 6 or 8 weeks ago. And again, I think parents are very concerned about the welfare of their children, as are, in fact, school districts, and equally concerned in the school district's case, and probably the parents' case, of the welfare of their teaching and non-teaching staff. So I think we've got a nexus in schools of lots of very responsible people who are, A, not going to send their kids back to school until they feel it's safe or have no choice, and B, those that do go to school, the schools themselves and their school district supervision will be focused on making it as safe as possible. So I don't really think complacency is going to be that big a deal in the school.
Okay. And then one last.
Apologize.
No, you're good. You're good. One last question, and that came to mind while you were speaking through some of those things was the issue of vaccines. I've heard so many times that we're just waiting until a vaccine comes through, and that then all of a sudden magically this is going to disappear. It's going to be our quick fix. And while we're aggressively working towards the development of a vaccine, is this going to be a quick fix even when one is available?
No. I wish I could say yes. I wish I could say that it's a silver bullet, it's a miracle. Here's the reality. There are at least 50 different vaccines in various stages of research and production at this point. 80% of vaccines fail, approximately 80% of vaccines fail in stage 3 testing, because that's the point where you expose a wide enough population with a wide enough variety of personal health conditions, physiological conditions, genetic predispositions. That's where you get the tens of thousands of people that give you a sampling that is relevant to the population as a whole. So of those, let's say 50, 80% of them are going to fail. So we're left with 10, right? We're left with 10 candidate vaccines. Most of the candidate vaccines are two-stage. So you get a shot or an inhalation in some cases, and you go away for a month, and then you come back and you have another shot or another inhalation. And it's the secondary inhalation that gets you to the point where you have immunity, hopefully. So there's a huge logistical challenge, there's a cost challenge, there's a compliance challenge. I mean, certainly in the US, there's an anti-vaccine movement that is implacably opposed to being vaccinated or allowing their children to be vaccinated. And to get to a level where vaccination gives us herd immunity, I think most people have heard that term now. It basically means where there are enough immune people that the chain of infection gets broken very quickly from an infected person. So the infected person can't actually infect the 3+ people they're used to, but typically 1 or fewer people. And so herd immunity leads to the reduction to a background level of diseases. Well, it requires about 70% of the population to have that immunity, either through having had COVID themselves or having been vaccinated. You know, it's going to take a long time for us to get to 70% of the population with immunity. And this sets aside 2 other really important things. There is some research at the moment that suggests that immunity conferred through having the disease, which is very similar to immunity conferred through vaccination, potentially fades fairly quickly. If you think about other diseases, you think about the flu, for example. You know, immunity to the flu's seasonal, so we have about 6 months of the year in the Northern Hemisphere where we're exposed to flu risk, and the other 6 months we're basically not, mostly because of ambient temperatures and sunlight. And if you think about the flu, your immunity does not last till the next year. It's gone, right? First point. Second point, we don't know yet the genetic drift rate of COVID. We don't know its mutation rate. Over time, most mutations in most diseases tend to be benign. So they tend to, if anything, reduce the severity of it. But there are indications that I think we're at currently strain number 30 on this disease, plus or minus, since it was first identified. And there are indications that some strains prevalent in some geographies are actually more virulent than the original. Vietnam right now is an example of that. So vaccination, not a silver bullet. COVID, it's probably with us forever, like the common cold and influenza. We will probably get better at therapies for it. There are therapies already known. There are new therapies being developed. Many of them are combinations of existing drugs or reapplications of old drugs that were effective for other uses. So we'll probably be able to reduce the severity of the disease and shorten the recovery period long before we actually have a population that has herd immunity.
Great information. Well, Mark, thank you so much for this information. Thank you for joining the webinar, for the live stream, for answering our additional questions. You're always a wealth of knowledge, and I appreciate you so much. Just a few quick mentions before we go. Next Thursday at 1:00 p.m. Central, we're going to be hosting another webinar on demystifying epidemiology and the role of public health. We're going to have Sarah McKinos, who's an epidemiology and the principal for data strategy consulting. She's going to be joining us. As you all know, epidemiologists have played a huge role in this pandemic, and I'm really looking forward to the insight that she's going to be able to share. So if you haven't already, please make sure and sign up for that, but also send us your questions in advance. You can send those to us at coronavirus@axiomllc.com. And if you're looking for additional information about risk mitigation, return to work strategies, etc., our excellent Chuck Cable, he's our Chief Legal and HR Officer. He's authored an excellent white paper called The World After COVID-19. You can access a free copy of that publication on our website. And as always, if you have any questions regarding Axiom's check into work, check into school, any of those, reach out to us. We'll be happy to walk you through it. So thank you again, and we'll see you at the webinar.